Okay, as we said before, the causes of short PR interval, including Wolff-Parkinson-White syndrome, it is an accessory pathway. This is called bundle of Kent that allow early activation of the ventricle. This is producing what is called delta wave and short PR interval, as we see here. If you see here, this is a normal conduction through the AV node. The normal conduction through the AV node here, there will be some delay, what is called, for instance here, from the electrical current from the sinusoidal node here to the AV node, to the through the AV junction and bundle office to the right and left bundle branch block. This is a normal pathway. In WBW syndrome, there will be an accessory path, which is a congenital one, so bundle called bundle of Kent that create a faster pathway that fast than the usual AV pathway. So this will create a shorter PR interval and forming what's called the delta wave in the ECG. Here you see this is a path, this is a accessory pathway here. It comes directly from the from the sinusoidal node through the atria to the ventricle. So this is creating a very short PR interval. Here it is represented by the red ECG, here. This is a short PR interval, and this is a delta wave. This is a delta wave here. Okay, this is a delta wave. Okay, this is one cause of the short PR interval. Okay, let us talk about we are talking about the intervals now, so we can talk about the QRS interval or duration. The normal QRS duration is from 110 to 120 millisecond. We can say millisecond or second. If we say second, we say 0.11 to 0.12 second. Any impairment of the conduction in the right or left bundle system, which is called intraventricular conduction abnormalities, can lead to prolongation of the QRS interval or duration. So we have either a problem in left or right bundle branches. If this problem is complete bundle branch block, right or left, this is the interval of the QRS complex exceed more than 120 milliseconds. That means more than 3 small squares in the ECG paper. More than 3 small squares in the. If you can say it is incomplete half block or incomplete right bundle branch block, or left bundle branch block, the interval will be less than 100. That's mean from 110 to 120 milliseconds. Okay. The causes of prolonged QRS interval is including left and right bundle branch block. So now we can talk about the bundle branch blocks, both right and left bundle branch block, and see how it looks and how it prolong the QRS complex. As you know, conduction in the bundle branches and the Purkinje fibers are seen as the QRS complex on the ECG. So the QRS complex reflects the electrical activity in the bundle branches and Purkinje fibers This is definitely transfer the electrical activity to the myocardium. So this is a time at which we could see the QRS complex. Therefore, a conduction block of the bundle branches would be reflected as change in the QRS complex, and definitely this is the prolongation of the QRS complex. Here you see this is the electrical activity in the right bundle branch block here. Yeah, this one here. You see the black X here. This is right bundle and it was blocked here in this point. So the electrical current here from the cyanoatrial node to the AV node to the AV node here to the black one to the bundle face, and then first it activates the left, then it goes from the left to the right, from the left to the right. So the axis will be from the left to the right. So any lead that face so the activity comes from the left to the right. So any lead that reflects the right will be positive. And you see here why the QRS complex here in the right bundle brush goes in the lead V1 and V2 here will be right and take this shape, what's called the M shape here, the M shape. Okay, here it is the V1 here and takes this shape, the M shape. This is the right bundle branch block. Okay, so we should only look at V1 and V6 and V1 maybe V2 to see the bundle branch block and the difference between them and the configuration of the ECG and the QRS complex in bundle branch block and how it prolongs the QRS interval. Here, this is a normal ECG. We are using V1 and V6. For the RBB here, sorry, I want to use the pen. For the right bundle branch block here, you see this is V1. We are talking about V1. We have this pattern of QRS complex, what calls RSR pattern in V1 or M shape. So it gives us a bizarre shape with T wave inversion in lead V1 here. This is R S RASR pattern here. This is the S wave. So, because the electrical current came from the left to the right, because the right bundle branch right bundle branch is cut or blocked, so the current come towards the right bundle. So it gives us the positive deflection or positive R wave in V1. This is why right bundle branch block has positive R wave in V1. We should know how to differentiate between left and right bundle branch by concentrating on V1, because here V1 looks reflect the V, the right ventricle. So the electrical current come in the opposite direction towards the V1. So it will be positive. And this is here, as you see here. And if you look at V6, we have a small q and then r and s with q r s here, and it is because the current now goes towards the v6 in the left. First it goes to the left because the right is blocked, so it choose the left bundle branch to activate the left side of the heart, the LV, first. Because the, then it gives positive R wave in V1 and uh, positive R wave in V1 and negative R wave and deep S wave in V6. If you see here, we have a deep S wave because the current now go away from the left to the right. Here we have the S wave. This is for activation of the interventricular signal. Okay. For the left bundle branch block, here we have complete the opposite. Here you will see we have the prolongation. The QRS complex is prolonged and wide, and if you see in V1 here, we have a W pattern here called the W pattern. Uh, okay, here it is W pattern. If you see it is here like that. And WM, this is in V1, and in V6 it is like that. So it's called William or WM pattern like that here. And the QRS complex is wider. Definitely it is more than 120 millisecond. Okay, here the same in the left bundle branch block. The left bundle is disturbed or blocked, so the current first come through the right bundle and activate the right side of the heart and then spread to the left. This is why it gives us this shape. Because the current goes from here, from right to left. So in V1 we will see it will be negative. As you see it's here in V1 it will be negative because of the abnormal current pathway. Okay. Here, this is what we explain. For the right bundle branch, the white QRS complex assume a unique visually diagnostic shape in the lead overlying the right ventricle. V1 and V2, you see, it is an M shape. It is an M shape. Here, you see, okay, this is an example of right bundle branch block. Just look at V1 if you want to know very quickly what's going on. You see here, just look at V1. Where is V1 here? It is here, V1 and V2. It took the characteristic M shape with wide QRS complex. Definitely if you count it, will be more than 3 small square, which is more than 120 millisecond. For the LBB, this is a normal ECG here. You see, this is V1 and V2. This is normal conduction. There is no widening of the QRS complex. It's duration more than 120 less than 120 millisecond. It's about two small square here. If you see it, is normal conduction. Negative deflection of the of the QRS complex. Okay. For the LBB, this is a normal one, and here for the LBB, the white QRS complex assume another characteristic change in the shape in those leads opposite the left ventricle. Opposite, this means lead V1 and V2. These are called the right ventricular lead. So if you see here, we have deep S wave here because the current now goes away from, because of the LBB, it goes from the opposite, from the right to the left. So it gives us negative deflection in V1 here, because V1 looks to right ventricular lead. It's called right ventricular V1. And you see in V6 also we have this is V2, also the same shape, broad deep S wave, broad deep S wave. Just look here to know the left bundle branch block again. We have deep wide S wave in V1, deep wide S wave in V1. It is here, and maybe V2 also, and maybe V2 here and here. Okay, intervals. Still, we are talking about intervals. Now here, this is a QT interval. The QT interval is measured in lead AVL because this lead does not have prominent U wave. You see here, better to be measured in lead AVL because the U wave here not prominent. So it measures the interval from the Q wave up to the end of T wave. This period. This is the QT interval. Okay, it includes the total duration of the ventricular activation and recovery. Yes, it represents the ventricular activation, both and recovery. We can measure it from as I said, in AVL, V2 or V3, because here we have no prominent U wave. Okay, what about the normal range? It is rate dependent. It is rate dependent, so it will be different. In patient with bradycardia, it will be prolonged, and in patient with tachycardia, it will be very short. So why it's called rate dependent? So we have to correct it, and we have what called corrected QT interval. We have an equation for that to correct the QT interval, and we have what's called QUTC. That is the corrected QT interval, which it is a sum of the QT interval divided by the square root of the heart rate. Divided by the square root of the heart rate. This is the corrected QT interval. Okay, what is the normal limit of the QT interval? It is about 450 up to 450 up to 460 millisecond. This formula called the Bazid formula, that the corrected QT interval is still have significantly affected by the heart rate even after correction, and many as 30% of normal ECG would be diagnosed as having prolonged QT interval, and it's normal by using the QT interval. We have another formula which is relatively insensitive to the heart rate. It is like that. Corrected QT interval equal the QT interval plus 1.7 multiplied by the heart rate minus 60. So this is a QT interval and the corrected QT interval, and how we can measure it, either using the Bazid formula or this formula, which is insensitive to the heart rate. Which is like that. The corrected QT interval equal QT interval plus 1.7 multiplied by heart rate minus 60. Here, this is the formula. This is the formula. Here it is. Okay. Okay. We can talk about the causes of this prolonged QT interval. It usually occur during sleep. It's normal. In the hypocalcemia, in patients with myocarditis, acute myocarditis, acute myocardial injury, drugs such as quinidine, procainamide, tricyclic antidepressant, anti-amiodarone. These are antidepressant or antiarrhythmic drugs. All of them can cause prolongation of the equute interval in hypothermia. Also, in patients with hypertrophic obstructive cardiomyopathy, it may be prolonged. Okay. Also, in patients with advanced AV block or high degree AV block, this patient will have bradycardia with prolonged QT interval. In a congenital disease such as Jervell-Lange-Nielsen syndrome and Romano-Ward syndrome. Jervell-Lange-Nielsen syndrome, it is a congenital it's a congenital disease associated with the neurosensory deafness, prolonged QT interval and deafness. This is Jervell-Lange-Nielsen syndrome. Romano-Ward syndrome is only prolonged QT interval but no deafness. This is some rare causes of prolonged QT interval. So, the shortened QT interval is occur in digitalis effect, such as digoxin, maybe hypercalcemia and hyperthermia, and in vagal stimulation also can cause short QT interval. Okay, you have a congenital, also congenital short QT interval. Okay, now we can talk about the QRS axis and what it represents. I think this is the summation of overall direction of the heart electrical activity. This is it can occur in a ventricular enlargement and the abnormal. It can occur in ventricular enlargement or conduction block such as hemi block. Can give us axis deviation. But what is a normal axis deviation we will see, and what is abnormal. This is the axis, the mean, or what we mean by axis. A QRS axis, it represents the direction of the summation of the direction of the heart electrical activity. We will see this here, and the QRS axis, the normal one, slice between the angle minus 30 and up to 90 degree. This is the normal axis. You see where this come from. This minus 30 and plus 90. These are the angles we already see before. You see before here. We magnify this. I told you as before, every lead lie on a special angle, and already we see this before. This is and the AVR, she lie at minus 50, and AVL lie at minus 30, and one lie at 0, and lead 3, lead 2 at the positive 60 angle, and 3 at 1 positive 120 angle. This is this here. So the normal axis lie between minus 30 and plus 90 angle. So what we have what's called left axis deviation, and what's called right axis deviation, and what's normal, and what's the indeterminate axis. Okay, the normal one, as we say, it lies between minus 30 here. You see this circle. Look at this circle here. Look at this circle here. We say that the normal lie between minus 30 here and positive 90 here. Okay, this is a normal axis. Left axis deviation, that means the axis is directed from the normal towards this direction here. This is the left axis deviation, lies in this angle from minus 90 to minus 30, and right axis deviation from positive 90 to the to positive 180 in this axis. Between positive 180 and positive and negative 90, this is indeterminate axis. Okay. Okay, and we see how we can determine that using the lead 1 and lead 3. Usually lead 1 here, it is positive. You see this here, lead 1 is positive and lead 3 is positive. And now here, if it is like that, this is a normal one. This is a normal QRS complex axis. It goes to this direction. If we just see the lead 1 is like that, positive, and lead 3 is positive. So the direction will be in the normal towards what we mentioned before. It will be normal and it will be towards this direction between minus 30 and positive 90. This is the normal direction of the heart you see here. Okay, determining the axis, we have two approach: the quadrant approach and the equiphasic approach. Okay, here we see here using the ECG, the QRS complex, we have to determine, as I mentioned before, we have to determine if it is predominantly positive, the leads are, this is the equiphasic, predominantly positive or negative or equiphasic. Here now you see it is positive, it's predominantly positive, and here it's predominantly negative, and here it is equiphasic. Here equiphasic, that means here in here the R and the S wave are equal. Predominantly positive, only the R wave more than the S wave, and predominantly negative, the S wave here more bigger than the R wave, bigger than the R wave. This is the equiphasic. That is the equiphasic one. The quadrant approach here, we look at the QRS complexity in lead 1 and AVF. Determine if they are positive or negative. We look at lead 1 and AVF and to determine if they are predominantly positive or negative. The combination should place the axis into one of the following. Here, if lead 1, here you see lead 1 positive. If lead 1 here, if it is positive, so this is normal axis deviation. Negative, this is right axis deviation. It is equivocal, it is indeterminate axis. Okay. Okay, sorry, I mean if it is positive, this is uh, uh, sorry, if lead 1 is positive and lead AVF is positive here, this is a normal, as you see the first ECG I show you here. Sorry, Go back here. This one. This is lead 1, and you can use both lead 1 or sorry. Is that one? Here we can use this lead 1 and lead 3. This is normal now. Assume this is AVF. If it's like that, so this is normal axis. If lead 1 and AVF is normal or predominantly positive, this is normal axis. Okay. Okay. If lead 1 is negative and lead AVF is positive, lead 1 negative here, and AVF positive, this is right axis deviation. Okay, if lead 1 is negative and lead AVF positive, this is right axis deviation. So what's indeterminate? If you have both lead are negative, this is indeterminate axis. I think this is easy. I'll give you some examples. For example, here, this is an example. You see here lead 1. What's about lead 1? What about lead 1 here? This is lead 1. Definitely it is predominantly positive, negative because R wave is S wave more than R wave. Let's go to lead AVF. So this is a AVF. This is a lead AVF. It is positive. So here we have negative lead 1 and positive AVF. This is right axis. This is how quadrant approach works. This is right axis deviation. Another example. Okay, negative lead 1, positive AVF. This is right axis deviation. Okay, another example. See, lead 1 here is predominantly positive and AVF negative. So, sorry. So, positive lead 1 and negative AVF. This is left axis deviation. Okay, that is a quadrant approach. You can use the lead 1 and lead AVF to determine the axis. What is the equiphasic approach? Here we use the most equiphasic QRF. What is the equiphasic? That means what? That means both R wave and S wave in that lead are equal. Here I show you one before here. This one. Sorry. This is equiphasic here. R wave equal S wave. So this is equiphasic. You can use this to determine the axis. I think so we can choose the most equiphasic QRS complex. You can look at the 12 lead ECG and see which one is equiphasic. Okay, here we need the angles. Identified lead lies 90 degree away from this lead. Okay, we can identify the lead that lie 90 degree away from the lead. So the QRS in this second lead is positive or negative, and we'll see that lead if it is positive or negative. According to this, here you see we can determine the axis. These are some example. These are some example here. Let us see this here. Which one is most equiphasic here in these leads? We have lead 1, 3, and AVF. Here I think this one look more equiphasic. That's mean lead 3. Lead 3 here, lead 2 here. Lead 2 here, it's more equiphasic. This one. This is lead 2. It's more equiphasic. And then we see which lead lie on 90° away from this lead. Here 90°, yeah, definitely it will be AVL, which is on -30. Now here the QRS axis is -30. It is simple like that. It is -30. Another example, which one equivocal here? This one. This time this lead one here is more equivocal. So and the lead dial 90° away, 90° like that means this is the AVF, and now the AVF here is on plus 90, so the QRS here is plus 90°. Okay, so again here you need to keep this in mind when you determine the axis, I mean the angle. Okay. So yeah, then we can look which one now here is more equivocal. Which one here is more equivocal here? I think the AVF here is more equivocal. AVF predominantly positive. And so the angle that lie is -0, so the car is 0, so the car is complete is 0 for the AVF. You get it? Okay, show you here how it comes. We choose AVF, that is more observable with the AVF here. This is AVF. This is the AVF here. This one's the AVF, and so the negative the 90° correspond angle is 0. You see, 0. It's simple, but it needs here this you need this you need this shape to be kept in mind. This shape, you need this shape to be kept in mind to determine the angle. So a shape like this, that's the insolvent triangle with all lead, and it, the angle correspond lie to determine. Anyway, we prefer using the equiphase the first the equiphasic way of for determining the axis. I mean we prefer the quadrant one to determine the axis. It is simple, and we don't need this equivalent triangle in front of us. Okay. So what the P, Q, R, S, T? What P and Q and R and S, T stand for? P definitely, and we talk about interval. It is atrial sorry, it's for atrial depolarization. Here is the P wave. What is the QRS? This is stand for ventricular depolarization. T wave for ventricular polarization. Okay, we will talk about everyone separately and in detail to make this very clear. It's okay. We are going to talk about the P wave. The way we are talking about this is the sequences of reading the ECG. First, what we see in the ECG, what if we take the ECG procedure, the first thing we have to look what, and we are coming in sequences. We look first for the, as I said, for the calibration or standardization. That means what? That means the ECG velocity should be 25 millimeter per second, and the calibration should be too big square. So this is the first we have to look for, and then after that we can determine the heart rate, and after the heart rate we can determine the the rhythm is it, before the heart rate the rhythm is regular, and the heart rate, and then the axis. After that, we come to the axis and the duration, the interval of the PQRS, PQCT, and then we come to the shape of these waves, P wave, Q wave, and R wave, and like that. To determine if there is unknown. This is the sequences how we read the ECG to determine the abnormalities. Now, here we are going to talk about the P wave. Always positive in lead 1 and lead 2. This is the normal. It's always positive in lead 1 and lead 2. Always negative in lead AVR. AVR it's always negative. So it is the duration about 3 less than 3 small square. As we told before, it is about the interval of the B wave 0.12 up to 20. Less than 2.5 small square, 2.5 millimeter in amplitude. This is the amplitude. It is less than 2.5 millimeter, and the duration less than 3 small square. It could be biphasic in V1, commonly biphasic in V1, and base seen in lead 2. This is a morphology. What is the morphology? It is length, and it is amplitude, and it is shape. Okay, it was negative in lead 1 and 2, and L was negative in lead AVR. So what the atrial abnormalities? We have right atrial enlargement. It will be tall, more than 2.5 millimeter, pointed P wave. This is what's called P pulmonal. P pulmonal. Uh, you see here, it is more than 2.5 millimeter in the right atrial enlargement. This is called P pulmonale, and you always better to see the in lead 2. In lead 2. This is P pulmonale. Notched or beefed shape is P wave, P mitral. In P mitral, also this is in left, that's right, and here now in left atrial enlargement. This is called P beefed or M shaped. This is P mitral, commonly called the mitral valve stenosis. That lead to left atrial enlargement deeply, and so it will be beefed or like that M shaped. Always look at it in the 2 or a V1 M shaped. So to diagnose left atrial enlargement, you can use the following criteria: lead 1 and lead 2, and more than 0.04 S between notched peak. or negative deflection more than 0.04. I think that this detail is not important. You should know that it is difficult. This is an example. If it UF indicate left atrial enlargement, this is a P mitral. Why P mitral? We say P mitral because usually left atrial enlargement occur in mitral stenosis. Left atrial enlargement is notch, P notch, PWF need two is notch are notch, and in one they have a deep and wide negative component like that. This is a characteristic of left atrial enlargement. Okay, this is example of P wave abnormalities. QRS complex. So here we will talk about what's the QRS complex and how it progresses in the precordial lead. Precordial lead from lead 1 up V1 or precordial lead V1 or dorsal lead V1 up to V6. So what is the QF? The QF, it's always the negative, the first negative deflection of the QRS complex. Here an example of Q wave. You see here the first negative deflection. Sorry, first negative deflection. Here this is Q. This is Q wave. It's clear. Here this one here Q. Sorry, I need the pen. I use it. This is a Q wave. First negative deflection. The first negative deflection. Q wave and S wave. So this is why it called S wave. Here, also here Q wave. The R wave. This is a first positive deflection. It comes after Q wave. Here, this is a R wave. This is an example of R wave. What's the S wave? It is a negative deflection. It comes usually after the R wave. It could be like that. Here we can say it is Q waves, and this is now it is Q R. Okay, Q R. This is only when we find first negative deflection like this here. First negative deflection like this here. It is Q. Okay, sorry. It is Q wave. Only negative deflection. The first negative deflection. This is a normal QRS complex. Usually we look at V1 here. It's like that, negative, and V6 positive, and we should know the transient zone. This is a normal here. Here V1 we see, and also we have a small R wave. Here this is small R wave, and then V6 here. This is a normal Q wave. We have a small R wave. As here we have small Q wave, which is called septal Q wave in lead V3. And here we have small R. This is what's called septal R wave in V1, and a small Q wave and septal Q wave in lead V6. Okay, let us talk about the QRS complex. The normal QRS pattern, this is already we mentioned. The normal QRS pattern in the precordial lead follow an orderly progression from right, this is from V1 to left V6. In lead V1 and V2, left ventricular free wall activation generates S wave following the initial small R wave generated by septal activation. So this is called RS pattern. That's the small R in lead V1 stand for the septal activation. As the exploring electrode move laterally, that means the left laterally to the left, the R wave become more dominant and the S wave become smaller or totally lost. Okay. In the leftmost lead, that's lead V5 and V6, the pattern also include the septal Q wave to produce the QRS or the QR pattern. That here Q stand for septal activation again because it goes away from it. So let us see the normal progression. Here from V1, you see here a small R wave, then V2, and if you see here now the R wave. The R wave, that is the positive deflection, the S wave. This is the transition zone now here in V3, then V4. It almost now the S wave disappeared, and now the dominantly here is the R wave. You see in V6 and V5 and V6. This is the normal progression of R wave. Early or delayed transition zone. Transition zone, what means? That means this where the R wave and the S wave are now equal. Uh, are equal. Here you see this is V1, V2, V3. Here this is earlier transition zone that occur in V2. That occur in V2. And here is the delayed transition zone that occur in V5. What is the difference? It is a normal variant, I think. Non-pathological Q wave may present in lead 1, 2, 3, lead 1 and 3, and AVL, V5, and V6 as we mentioned before. Pathological Q wave, it is always more than 2 mm. Pathological Q wave more than 2 mm deep and 1 mm wide, or you can say more than 25% amplitude of the subsequent R wave. So the pathological one should be more than 2 mm deep and more than 1 mm wide, or you can say it's more than 25% amplitude of the subsequent R wave. You should consider it pathological if it's like that. Otherwise, we have non-pathological QEF, lead 1 and 3, and AVL, V5 and V6, which is small, is less than 2 mm and less than 1 mm in wide, or less than 25% amplitude of the subsequent R wave. Okay, we can talk about the QRS in left ventricular hypertrophy and right ventricular hypertrophy. Okay, this is a you see here the main vector or the axis. It was V6 here, and you see this is a normal towards left. That means what? In the V1 it is negative and V6 positive, as we mentioned before. What's happening in left ventricular hypertrophy? The septum will be more hypertrophied and enlarged. So we expect the vector here or the amplitude will be bigger. You see here the amplitude in the left ventricular hypertrophy will be bigger in both in V1 and V6. So to diagnose the LVH, the amplitude of S wave in V1 and R wave in V6 will increase, and it will be more than 35 millimeter. This can diagnose the LVH. On the RVH here, in the RVH, here you see, because right ventricle is hypertrophied and the vector here is towards right ventricle, so the R wave here will be in V1 will be positive. You see here it will be positive. The R wave, the R wave will be positive in V1. Here it is. Here, sorry, be positive. Or like this, or like this. And we have also R wave, S wave in V6, S wave in V6. This indicate right ventricular hypertrophy. Right ventricular hypertrophy. It's in a simple way. It is in very simple way. So we have a lot of criteria to diagnose the left ventricular hypertrophy. We have also Collo and Lyon criteria. To see that here we see S wave in V1 and plus R wave in V5 or V6 more than 35. Okay, an R wave of 11 millimeter or more in lead AVL is another sign of LVH. It's very simple, just calculation to diagnose the LVH. Okay, for the right ventricular hypertrophy, we mentioned all this in the ECG example I gave for you. But here, the numbers, the R wave in V1, they will be R wave in V1, which is abnormal. It be more than 0.7 millivolt. We have Q, R in V1, the R to S in V1 more than 1 with R more than 0.5 millivolt. This R to S. R to S is more than 1. That means we have an R wave in V1 and it is more than S wave. R to S in V6 or V5 or V6 less than 1. This is the ratio between R and S. It would be more than the ratio between R and S. It would be more than 1 in V1 and R to S ratio in V1 or V5 and V6 to be less than 1. S in V5 or V6 more than 0.7 millimeter mercury. Yes, we have S wave in V5 or V6 be more than 7 millimeter mercury. You just saw this before. Not here the numbers. These other criteria include right axis deviation. And we have S1Q3 pattern and S1, S2, S3 pattern and P pulmonale. These are all right ventricular hypertrophy signs. You will see some of them here to be for being clear. Okay, to diagnose right ventricular hypertrophy, you can use the criteria. We have right axis deviation and R wave more than 7 millimeter tall. This is in V1. Here you see V1. We have R wave. This is abnormal. This is always in a normal one. It is negative, but now it is positive. You see here V1, and it's always more than 0.7 millimeter, 0.7 or 7 millimeter tall. 7 millimeter tall. That means it is one big square plus two small square, right? And we have also right axis deviation. We see the axis deviation. Look at lead 1 here, lead 1. For to determine the axis deviation, we have to look for lead 1. This is lead 1. What do you see here? If you see here that S wave is more than R wave. And look at V AVF. Where is AVF here? Sorry, this is AVF here. This is the AVF. I will draw red circle. This is the AVF. It is a positive here. So this is right axis deviation. We have right axis deviation because in lead 1 we have taller S wave more than R wave, and we have positive R wave in V. This is left axis deviation with positive R wave in V1. So this is RVH, right ventricular hypertrophy. This is right ventricular hypertrophy. Okay, we stop here and then we can talk about ST segment in the coming lecture. Thank you.